What is ROS1? We're going to dive deeper into ROS1 now. ROS1 gene is located in the chromosome 6, and it encodes a receptor tyrosine kinase that is part of the insulin receptor family, and it goes in the cell surface. It's very similar to the ALK receptor. The sequence of amino acids, it's equal in more than 50%. So that's the explanation why some of the drugs that work for ALK work also very well for ROS1. Now, ROS1 fusions are oncogenic. They were first identified in human glioblastoma cells several years ago, and the first partner that was identified attached to ROS was FIG, or fix in glioblastoma. The second tumor reported to have a ROS rearrangement was non-small cell lung cancer, and since then it has been reported in other tumors, including cholangiocarcinoma, ovarian cancer, gastric cancer, colorectal cancer, and angiosarcoma. So when you look at these fusions, the particular part on ROS1 is that there are at least 14 partners available for fusion that we know of. And this is different, for example, with ALK, where you have only one partner, EMLA4. Out of these 14 partners, the most common one that we see in lung cancer is CD74, or cluster of differentiation 74. So you have ROS1, CD74 together. In the other percentage, so different partners play a role. And at this point, whether you have a CD74 or non-CD74 partner does not seem to be important yet. But some of the newer publications are looking at the fact that CD74, when a partner for the fusion, may have more aggressive behavior towards the CNS and therefore worse prognosis. So stay tuned on that. So these ROS1 fusions are oncogenic, and they lead to a ROS1 kinase unregulated activation. The example I give to the patients is the light switch is always on. It's not on demand. If it's dark, you turn it on. If it's light, you don't. Here, it's always on, and it's activating intracellular pathways like JAK-STAT, PIK3, and MAPK, which are the ones that lead to the behavior, malignant behavior of those cells. So I'm going backwards. These fusions are usually seen in adenocarcinoma histology, very rarely in other histologies like large cell or squamous. The incidence of ROS1 rearrangement is 1 to 2% of non-small cell lung cancer. If you do the math based on the numbers we saw in 2021, for example, we should be seeing anywhere between 2,000 and 4,000 new cases of ROS1 fusion non-small cell lung cancer every year in the United States. The clinical features of ROS1 malignancy is very similar to ALK, affect patients that are younger. Usually we see that in non or light smokers, and it has a higher tendency to affect the central nervous system with brain metastasis. On average, about 36% of patients have brain mets. And to put it into context, on a non-small cell lung cancer that doesn't have any molecular abnormality, the rate is usually 10 to 20%. And if you look at ALK, which I'm sure you already heard before, the incidence is closer to 50%. So it's more common in women, and when present, is mutually exclusive with other alterations. ROS1 positive tumors should be treated with targeted therapy. That's an important concept. Now, to do that, you need to identify them. And how do we make the diagnosis? We need to do testing on the tumor. And you can do immunohistochemistry. You can do fluorescence in situ hybridization, what used to be the standard for ALK and ROS at the beginning. You can do PCR. But most recently, we're doing next generation sequencing. And when you look at the differences, there are advantages and disadvantages related to price. Turnaround time, for example, if you use IHC, you're going to get your results very quickly compared to NGS. But at least in the United States, we're using NGS because it does simultaneous testing. You have several tests running on the potential targets you can use, and it has a little bit of longer turnaround time. You have to pay attention now whether the panel you're using is DNA-based or RNA-based, because the sensitivity may be different. All of the ROS1 targeted drugs are multi-kinase inhibitors. And at this point, we have 2 FDA drugs that are approved: crizotinib, approved in 2016, and entrectinib, approved in 2019. There are other tyrosine kinase inhibitors that are available, but they are not approved. They include ceritinib, brigatinib, lorlatinib, repotrectinib, and most recently, taletrectinib. And you have heard these names in prior presentations today.